Hello, I'm Dr. Laukin, and thanks for joining me for a discussion about considering radiation treatment to the breast area if a person has already had at some past time radiation to the breast or chest wall. So let's suppose that a person had breast cancer and breast radiation was part of the first care plan. And then, after some period of time, in the same breast, cancer was found, for example, on a surveillance mammogram, or perhaps the person noticed a lump. So here's, for example, a case where in 2002, a person had a cancer in the upper part of the breast. It was a relatively small cancer. It was removed, the breast was preserved, and radiation treatment was given to the whole breast. And then let's suppose that in 2025, a follow-up mammogram is done as part of routine surveillance, and it shows abnormal finding in the lower part of the breast, and this is proven on biopsy to be cancer, and it's removed. Where to go from here? So first of all, to get a sense of that new cancer finding, is it somehow a leftover from the original cancer, or is it truly a brand new process? And we can get a few clues by studying that new cancer. First of all, its location. Let's suppose it's far away from the original location. Its appearance. Let's suppose it looks way different than the original cancer under the microscope. And then finally, let's suppose that a long, long time has passed. Well, if those things are true, then it's more likely that this new cancer is truly new rather than uh, related uh, and lingering somehow from the original cancer. And so if it is a new cancer, we can approach it truly on its own merits. And then we have to think about, well, what to do with the remainder of the breast. Remember, the first time, the person had radiation treatment to the whole breast. And so what are our choices now? Well, one is just to do nothing else. After all, the visible cancer has been removed. Another, and this has been the traditional approach if there's been a new invasive cancer after an original breast conservation and radiation treatment, is to remove the whole breast and say, well, we've had our chance with the radiation the first time, the cancer's come back. Let's be really proactive and remove the whole breast. Another approach is to say, well, gosh, it's been years, and what about using that radiation again? So we put that on the table as a choice. And then a final choice is medications. And we're going to look at each one of those choices. So let's suppose we do nothing else. Well, if this is a new cancer in the breast, if we look at what's been learned over the years, there's probably about a 1 in 4, 1 in 5 expectation that there'll be yet another cancer event. So one's motivated, if it's possible to do something more, to try to bring that probability down. So the old standard was to remove the breast, but a mastectomy surgery for many is something that they would really prefer to avoid if at all possible. And indeed, the breast might be removed with nothing at all to find in it. So again, it's a matter of looking at individual risk preferences. Now, what if the new cancer is hormone receptor positive? And that is a cancer that is responsive to the hormone environment of the body. And it happens that those kind of cancers can be suppressed with a variety of medications that either block hormones from interacting with the cancer cells or that diminish the source of the hormones. And so there are medications like anastrozole, letrozole, tamoxifen that overall reduce the chance of cancer coming back, and that's both in the breast and in other places. And there have been some very well conducted studies that show that if a relatively small hormone receptor positive cancer is removed, especially in a person who's over, say, 65, 70, and if a person takes that medication for a number of years, that in at least 9 out of 10 cases, there's no further sign of that cancer coming back in the breast. And so that's a real improvement over doing nothing, and it's often a good choice. And in those studies that have looked at the question of using just the medication alone after lumpectomy in an older person, that the use of the medication keeps the what we call the long-term survival rate right up there. That is that many, if you're in that 10% that has the cancer come back, that often can be what's called salvaged with something else at the time. And so one doesn't lose ground on the probability of being alive, say, 10 years down the road. Now let's turn to the question of radiation. Can it be used again? And the old answer was, well, it's best not to. And there's kind of a newish answer that says, well, sometimes it can be a reasonable choice. And so one should think about the risks and benefits in an individual case. And because often, not always, a recurrence can be sort of around the area where the cancer was found, that it's often thought of to do just radiation to part of the breast, to the area where the new cancer was removed. So where did the idea of it's best not to come from? Why not reuse radiation? And it's because normal tissues have a certain tolerance to radiation. If you give too much, you cause a formation of scar tissue, uh, and that scar tissue can impact the blood supply. Blood vessels can be narrowed, and the tissue becomes unhealthy. And with that, it can become painful. There can be a risk of infection, breakdown of the skin or underlying tissues, and that can be really hard to heal. And when we're looking at the breast treatment, we think of the soft tissues of the chest wall or breast and the underlying muscles and rib cage, which could be potentially at risk as well. So over the years, there have been some studies. They've been done, for example, in people that have had the cancer come back in the breast and they absolutely and categorically refuse to have a mastectomy. And so some experience has been gathered with retreating the breast area with radiation. And as an example, a study done over 20 years ago took about 40 cases and used partial breast radiation and said, well, that worked out pretty well. Well, 1 in 4 had either a marked deformity or marked size difference, and that would be in keeping with forming scar tissue. But the majority didn't. And since these were people that really sought out this treatment because they didn't want a mastectomy, they were said to be satisfied. And most of them, not all, but most of them had ongoing local control when they were checked in follow up. So, well, maybe there is a place to try again. And if we look at more recent studies, here looking up to, say, the year 2020, one that's had a lot of visibility involved about 60 patients that were treated after 2010, and they were treated with partial breast radiation on a particular schedule. And what they found was that with a 5-year follow-up, the risk of a recurrence was about 5%. But some of these people were also taking those pills that I've referenced, so there can be more than one reason that that recurrence rate was fairly low. When they looked at adverse or side effects of the treatment, about a third had meaningful ongoing side effects more than a year after treatment. Some bother in about 1 in 4, and in about 7%, quite a lot of bother, called severe, in terms of skin effects, scar tissue effects on deep tissue, breast pain, breast shrinkage. So about 2/3 didn't. So the conclusion of this study is that you carefully considered partial breast radiation. It certainly feasible. It can be on the table as a tool, but clearly there is a risk of having these extra side effects because you've really pushed the radiation dose cumulatively to those normal tissues. So, to take a stand on it about breast radiation being repeated, well, it is an option. But when we look at the information available, even though there's a number of small studies, they might have 20, 30, 40, I mean, 60 patients is a lot. So there's not a huge amount of published experience. And those experiences are often 5 years of follow up. And that's still pretty short if we're looking at really long term survival. And we see that about 1 in 3 could have meaningful, bothersome, lingering problems caused by that radiation impact, scar tissue formation, skin effects, and so on. So I think the takeaway is if you have other choices, don't rush into second time around radiation. And it might be a consideration for someone who doesn't have any visible signs of long-term radiation effect from their first round of radiation. And let's suppose that there are features of the tumor where those pills aren't going to be helpful if they don't have those positive hormone receptors, and where they're really have a heart absolutely set on avoiding a mastectomy. But for people, say, who can take those pills, they're often a very good choice for someone who wants to preserve the breast and is prepared to have some ongoing follow-up because, as I mentioned, 9 out of 10, odds are that they can go a decade without encountering other problems. So thanks very much for listening to this discussion. And if you're going to be seeing me about this issue, I look forward to meeting you.